rehabilitation of dental problems. 3. The promotion of dental healthcare services by His Majesty the King's Dental Service Unit, together with partners and networks, utilizing innovations developed domestically. 4. Organizational development to increase capacity in the invention of innovations towards continuity and sustainability. During the first phase of research and development, the Foundation placed emphasis on several oral diseases in the elderly, such as oral cancer. Oral cancer patients suffer tremendously as they are unable to eat and must be fed via a feeding tube. Patients also risk infection and pain when the tube is inserted into the throat. Dental Innovation Foundation, under royal patronage, partnered with the dentistry program under Anantamahidol Scholarship. Assistant Professor Dr. Arunwan Lam Ubon and Assistant Professor Dr. Dunyaporn Trachutham. Dentists who had been granted Anantamahidol scholarships to study in the United States of America to major in oral cancer and other related fields of study have led the research and development team to find solutions to these issues. The partnership had led to an innovative research and development project on food for oral cancer patients. The success of this project was a food product that allowed oral cancer patients to eat and not having to use a feeding tube. It was called NutriJelly. In the second sub-project, NutriJelly was further developed to add anti-neoplastic agents for oral cancer. This has better benefited the patients, providing them a higher chance to be cured. Another problem that occurred in older patients and oral cancer patients treated with chemotherapy was salivary gland disorder, causing dry mouth and insufficient saliva production. The two dentists researched and experimented until they could develop artificial saliva to solve the problem for such patients. This innovation is called moisturizing jelly. Furthermore, the Foundation invented medical devices to help prevent dental decay and root caries, resin pit and fissure sealants, as well as fluoride varnish.
สำหรับที่มาของอาคารปฏิบัติการหน่วยทันตกรรมพระราชทานในพระบาทสมเด็จพระเจ้าอยู่หัวนะครับแล้วก็โรงงาน
สวัสดีครับ Welcome to the 5th online webinar of King Rama IX Dental Implant Development Center Study Club. Today, it's very honored to have Professor By.Ghali with us in the topic of current management of head and neck cancer. First of all, I would like to introduce Professor Ghali. Professor Ghali is an oral and maxillofacial surgeon in Shreveport, Louisiana. He has served as a professor and chairman of the Oral and Maxillofacial Surgery Department for the past 15 years. In October 16, he was named Chancellor and Dean of the Health Science Center. He subsequently relinquished the role of the Dean to focus on negotiation of the new hospital partner, resulting in a joint venture with Ochsner Health System, which is effectively since October 1st, 2018. He is very active in residence, fellow, and student education, with appointment to numerous committees keeping LSU Health Shreveport at the forefront of medical care and education in Louisiana. Professor Ghali has continued to serve in national and international organizations such as AAOMS, ABOMS, and IAOMS. Professor Ghali's association with This organization is recognized in shaping the profession of the oral and maxillofacial surgery, as well as providing international recognition for the LSU Health Support Residency and Fellowship Program. Professor Ghali has numerous research interests, including clinical and basic science research. He has published a numerous peer-reviewed journals, written many books, chapters, and has edited textbooks that are vital to the knowledge base of many in the specialty. Please welcome Professor Ghali.
Thank you. Can you hear me okay?
Yes.
Thank you very much, Mr. Goodman. I want to thank His Majesty the King for allowing me to speak at this esteemed Dental Innovation Foundation. I would also like to thank my very dear friend, Dr. Wichit Theranon, for suggesting me to speak at your conference. Without further ado, I would like to begin. This is the Health Science Center, one of 5 campuses in Shreveport, Louisiana, that I currently practice the full scope of oral and maxillofacial surgery, including ablative and microvascular head and neck reconstructive surgery. My other areas of interest include craniofacial and cleft surgery, as well as orthodontic surgery. Today, the topic is current management of head and neck cancer. And I was very happy to hear from Wichit that the practice of head and neck surgery and oncology is growing in Thailand. And I look forward to coming and visiting Thailand again in the very near future, as I have maybe made at least 4 to 6 trips to Thailand over the past 30 years. But I'm very much looking forward to having a trip in the next year to visit my friends and to help expand the knowledge of oral and maxillofacial surgery in Thailand. If you look at head and neck cancers, really they can be divided into 3 major categories: skin malignancies, aerodigestive malignancies, and endocrine malignancies. Of course, the skin malignancies we won't be discussing today, but these include melanomas and non-melanotic lesions, things like squamous cell carcinoma of the skin or basal cell carcinoma of the skin, and of course the melanomas. A lot of research has been done in the past 20 years with melanoma, particularly using immunotherapy in the management of these very complex and highly metastatic lesions. But really the focus today is going to be more on the aerodigestive cancers in the head and neck, and particularly those that involve the mucosa of the oral cavity, the lips, the oral cavity, the tongue, the floor of mouth, the palate, and the oropharynx. We won't really discuss salivary gland tumors in much detail today because that is a completely separate topic, nor will we discuss the endocrine malignancies, which include the cancers of the thyroid and the parathyroid gland. If you look at oral or oropharyngeal cancers, what I'd like to discuss today is divide up into these areas: a little bit about epidemiology, a little bit about etiology and risk factors, discuss the common locations of oral and oropharyngeal cancers, what is involved in a diagnostic or metastatic workup for head and neck cancer. What about the TNM staging? There's been some minor changes, but for the most part, it's stayed fairly consistent over the past 10 or 15 years. A little bit about regional versus distant metastasis. How do we manage the neck in oral cavity cancer? What do we do for the neck? and then a couple of different case examples and show what's new in the past 10 or 15 years in the management of head and neck cancer. When you look at oral cancer in general, which is the main topic of discussion, in the United States, there's about 23 to 24,000 new cases per year. This was an estimate from, the most recent estimate from 2009. In the US, that resulted in over 5,000 deaths. But as you know, in Thailand and in other parts of the Indian subcontinent, the use of various environmental agents causes a higher risk of oral cancer in certain populations. And so the numbers in the US are fairly small compared to other parts of the world. 90% of the oral cancer, 90% of it is squamous cell carcinoma. There's some minor sarcomas and other lesions, melanomas and things like that. But for the most part, 9 out of 10 oral cancers are going to be squamous cell carcinoma. If you look at the data from the National Cancer Institute in the United States, 97% of oral cancer occurs in adults greater than 35 years of age. The most common location is going to be the tongue, floor of mouth, oropharynx, and tonsil. This is including all of the oral cavity. But within the oral cavity proper, within the anterior part of the oral cavity, where most of the dentists and oral surgeons are dealing with, it's mainly tongue and floor of mouth, most common sites. If you look at the cumulative age-adjusted incidence of oral cancer, it has a slightly higher incidence in the African American or the Black population, and a slightly lower incidence in females compared to males. Again, the histologic variant I just mentioned, most of these are going to be squamous cell carcinomas. A very small amount are going to be minor salivary gland tumors, melanomas, lymphomas, and sarcomas. So the majority of it is going to be squamous cell carcinoma. If you look at the risk factors for the development of oral cancer, by far, tobacco and alcohol are the most common of oral cavity proper squamous cell carcinomas. There has to usually a history of tobacco or a history of alcohol. When we get into the oropharynx, tonsil, base of tongue, hypopharynx, then human papillomavirus or HPV becomes a more common etiologic risk factor. We'll talk about that in a minute. Then there's the condition called candidal leukoplakia or chronic hyperplastic candidiasis that maybe you learned and you can remember from dental school. This is a condition that's considered to be a risk factor. It's a subtype of leukoplakia, which results in a high incidence or high risk factor for oral cancer development. As I mentioned a few minutes ago, and interestingly, in certain parts of India, in the Indian subcontinent, the use of betel nut, where they chew the betel nut or areca nut, really has a high incidence of development of a condition that you may be familiar with called submucous fibrosis. In the submucous fibrosis has about a 40 to 50% transformation rate to squamous cell carcinoma of the oral cavity. Very difficult to treat, difficult to access these patients because of the trismus that they also have. Chronic iron deficiency anemia is a contributing factor, as is certain immunodeficiency states. If you look at tobacco, in general, tobacco is time and dose related as a risk factor. If you look at the whole body, not just the oral cavity, but the whole body, about 35% of all cancers are going to be linked to the use of tobacco in some form or fashion. When you look at oral cavity cancer, about 75% of all oral cancers are associated in some form with either smoking of tobacco, chewing of tobacco, or something like that. And of course, cigars and pipes also are equivalent to the risk of cigarettes in most studies. If you look at the smokeless or the spit tobacco, which is common in certain rural areas of the United States, it's really increased in incidence. And the most common cancer type that the chewing tobacco compared to the smoking tobacco, the most common subvariant of carcinoma is the verrucous carcinoma. And we've come a long way. If you look at this advertisement on the right screen, this used to be very common to advertise cigarettes in magazines. And of course, now this has been outlawed in the United States, where you cannot advertise for cigarettes anymore. And this advertisement is actually saying that more doctors smoke Camel than any other cigarette. So things have changed quite a bit over the last 50 years. This was an advertisement from the 1940s in the United States. As I mentioned, alcohol seems to have both local effects and systemic effects. The local effects are acting as a solvent. The ethanol acts as a solvent, which may somehow cause the impurities in the tobacco to penetrate the mucosa easier. So it creates less of a barrier to these carcinogens. There's also contaminants that may be present in the alcohol. And again, it alters the epithelial metabolism. There obviously are systemic effects that you're aware of alcohol. This includes the ability to cause injury to the liver, as well as other nutritional deficiencies. This injury to the liver results in a reduction of the liver's ability to potentially detoxify carcinogens, which then may lead to other cancers within the body. We mentioned human papillomavirus, or HPV. The most common type we're talking about is HPV-16 or P16. Almost all of our cancers nowadays that we're biopsying, we are getting a P16 level on that specimen to see whether it is HPV related or not. The HPV related cancers, as you know, have an overall better prognosis and are more sensitive to chemotherapy and radiation compared to the traditional non-HPV oral cancers. Of course, a majority of these at the current time occur in the base of tongue and in the tonsillar region. HPV-related oral cancer is considered a sexually transmitted disease for the most part. If you look at the diagnostic workup of the aerodigestive cancers, particularly the head and neck or oral cancers, you have to do a good history and physical exam, a very focused exam in the head and neck area, which oral surgeons and dentists are very capable of doing. And then as part of the metastatic or diagnostic workup, we always get a PA and lateral chest x-ray, as well as liver function test. The two most common sites of spread outside of the head and neck is to the liver and the lungs. So we need to do some type of studies, blood studies, liver function tests, and chest x-ray on these patients. Additionally, we will do a panendoscopy. In most cases, the panendoscopy, which is going to be done at the time of the surgery. In rare cases, like yesterday, I had a patient, actually today, I had a patient with tonsillar cancer, which was difficult to examine in the clinic because the patient was gagging severely. So I ended up doing a formal panendoscopy on them today, where I put them to sleep and did a clinical exam on the patient with using fiber optic as well as direct rigid laryngoscopy. So I had a better idea of the full extent of the lesion. Certainly, if it's a tongue cancer, lip cancer, floor of mouth, palatal cancer, we rarely have to put them to sleep separately for those. But in some of the hypopharyngeal lesions, tonsillar lesions, base of tongue lesions, or laryngeal lesions, oftentimes we have to put them to sleep separately and do a panendoscopy so we can get a full assessment of the extent of the lesion. We will also get CT scans on the patient. And in certain patients, we will get a PET scan as well as doing a preoperative additional biopsy. All of these patients are going to be biopsied because we need a tissue diagnosis before we can really formulate an appropriate treatment plan for the patient. As you saw from the previous slide, this patient has a mass in their neck. As you recall, the neck really has 6 major lymph node levels. These include level 1, level 2, level 3, level 4, level 5, and level 6. In this slide, level 1 is labeled as A, level 2 is labeled as B, level 3 as C, level 4 as D, level 5 E, and of course the central compartment, which is level 6. Some of these levels may be subdivided as well. You can see basically that a majority of the cancers that originate in the oral cavity will spread to levels 1, 2, and 3, the majority of them. The hypopharyngeal lesions, the laryngeal lesions, and the thyroid lesions tend to spread to levels 4, 5, particularly 4 and 6, but maybe 4, 5, and 6. So when we talk about the most common sites, we're talking about the A, B, and C, which is levels 1, 2, and 3. You can look, as I mentioned before, level 1 is subdivided into a 1A and 1B. Level 2 may be subdivided into a 2A and 2B. And of course, level 5 may be divided into a 5A and 5B. And again, when you talk about the oral cavity, it's important to remember that most of the studies have shown that rarely does anything spread involve level 5 or level 6. Generally, it's going to be level 1, 2, and 3, occasionally level 4. So most oral cavity cancers can be picked up in the nodes of levels 1, 2, and 3, or what we consider the supraomohyoid levels. And that's the whole rationale for doing a selective neck dissection and only doing levels 1, 2, and 3, sparing level 4 and level 5, and certainly level 6. When we talk about the panendoscopy, or sometimes referred to as a triple endoscopy, always includes a direct rigid laryngoscopy, a nasopharyngoscopy, and an esophagoscopy. If the esophagoscopy is positive, then it would include a bronchoscopy as well to look at the lungs. But for the most part, the laryngoscopy, nasopharyngoscopy, and esophagoscopy. In most cases, rigid. In some cases, you may use a flexible scope. The benefit of doing the panendoscopy, just like today that I did, is because I want to get a better assessment of the extent of the primary tumor. We only do this about 5% of the time. In a majority of the cases, the panendoscopy is done at the same time as the definitive surgery in the beginning. In about 5% of the cases, we may do it separately when the lesion is very difficult to visualize, or the surgery is going to remove a large portion of the tongue, base of tongue, or the larynx or something like that. So the other additional benefit is it helps assess for any second primary lesions. So remember, you have synchronous lesions and you have metachronous lesions. A synchronous lesion is a lesion that occurs at the same time as the primary lesion. That only happens about 2 to 5% of the time. Then there's metachronous lesions, which are lesions that occur in the future. And of course, everyone knows with oral cancer, there's a high rate of recurrence. So we always have to monitor the patients, put them on surveillance, see them back twice a year for at least 5 years. So there's synchronous lesions, which may be picked up at the panendoscopy, or there's metachronous lesions, which are picked up in the future during the surveillance of our head and neck cancer patients. Also, we mentioned CT scanning and the importance of CT scanning. And of course, I only show this slide. You can see this large, very large lymph node. I hope you can see my pointer here. This is a very large lymph node with an area of central necrosis. So the CT criteria has not changed since the early 80s. A discrete non-enhancing mass greater than 1.5 centimeters, central reduction in lucency or area that you can see here like this, poorly defined or irregular borders, or a combination of ill-defined borders and loss of planes. This gives you a high index of suspicion that there is, at minimum, microscopic and more than likely gross invasion of the lymph node by the squamous cell carcinoma. Recall the TNM staging in the United States. It's very commonly used, and I think it's almost used worldwide in many countries by the American Joint Committee on Cancer. The most recent one was the 9th edition in 2019. It looks at the TNM, the size of the tumor or the size of the primary, the nodes, which are the N, and any M, which is distant metastasis. This allows a surgeon to design treatment strategies, compare results between one institution and another, and assess the prognosis of the patient. The primary tumor, as you know, is based on size, T1 being 2 centimeters or less, T2 is 2 to 4 centimeters, T3 is greater than 4, and then T4 depending on if it's located in the lip or whether it's in the oral cavity. And for example, a squamous cell carcinoma or any tumor which is invading or involving the masticator space or the base of skull, particularly the masticator space, which results in trismus, is automatically a T4B lesion. So this is really important. And then also looking at the lymph nodes, the N component of it. And we'll talk about this. The most important prognostic factor in oral cancer is the presence or absence of lymph node metastasis. The number one prognostic indicator is the presence or absence of lymph node metastasis. So this is critical. Once you have a lymph node that is positive, automatically you go to stage 3 cancer, and automatically your 5-year survival is reduced significantly. So this is an important factor. And then the M is the metastasis. Do they have no distant metastasis, or M1 is distant metastasis is present? Then you take the T and the N and the M and you put it together and you look at the stage groupings, and it shows you here, again, stage 1, obviously, to stage 4. Stage 1 having the best prognosis, a small lesion, less than 2 centimeters, a lesion that has no lymph node involvement, and a lesion that has no metastasis. As I mentioned before, once you have any, regardless of the size of the primary, whether it's a T1 or a T2 or a T3, if you have an N positive node, then this goes to stage 3. Remember, this is a clinical staging. This is not a pathologic staging. We do a clinical staging, then we do the surgery, which will include the primary and the margins, and then the lymph nodes. Then once we have these specimens submitted to the pathologist for histopathologic evaluation, then they'll restage the patient based upon the true pathology of what's noted in the lymph nodes, as well as the margins and the size of the tumor. So there's clinical and there's pathologic staging. If you look at the stage distribution for squamous cell of the oral cavity, a majority of these are discovered in stage 1 and stage 2. That's great, because the earlier it's discovered, the better prognosis for the patient, obviously. But still, there's almost 30% of patients, at least in the United States, that are discovered in stage 3 and stage 4, unfortunately. So the role, what is the role of the oral surgeon? What is the role of the dentist? The role is to find the cancer in stage 1 and stage 2. That's the biggest role, is to find the cancer in the early stages, hopefully stage 1. So the patient has the best prognosis. The treatment is less aggressive. and the overall survival is improved. I mentioned a minute ago regional metastasis into the nodes in the neck. This is the number one prognostic factor. Once you have a positive neck mass, neck node, your cure rate is reduced by 50%. The risk factors for spreading to the neck are the site, meaning that the location in the oral cavity. Some areas of the oral cavity are more prone to early metastasis to the neck. What are those? Those are the tongue and the floor of mouth. The other variable or the other risk factor is the T stage. The larger the lesion, the more likely it is to spread to the lymph nodes. So if I have a lesion in the tongue and it's a T1 lesion, its T1 is less likely to spread than a T3 or T4 lesion. But again, not 100%, but that's sort of a general rule, and we'll talk about that in just a minute. I mentioned this earlier, oral cancer and regional assessment. If you look at the N0 neck, so this is a patient that has a oral cavity cancer, and you palpate the neck and you feel no palpable adenopathy. In that patient, if there is potentially spread, which is microscopic, that you can't palpate, it's microscopic, 90% of the time it will be restricted to microscopic spread to levels 1, 2, and 3. Only 3% will go to level 4, and less than 1% will go to level 5. If you have a patient that has the same oral cavity cancer and they have the clinical exam shows a palpable lymph node, then the rate of spread to level 4 goes up to 20%. To level 5, 4%. So level 5 still not significant. But level 4, if you have a lymph node that you feel in level 1 or level 2, the patient has an oral cavity cancer, it might be wise to include level 4 in the dissection, right? Level 4 would be wise to include in the dissection. So if you have an N0 neck, you can probably restrict your dissection to levels 1, 2, and 3. What you see here on the diagram, the supraomohyoid levels. So remember, sternocleidomastoid muscle, and here is the omohyoid muscle. So this omohyoid muscle in the posterior border of the sternocleidomastoid and the inferior border of the mandible and the anterior belly of the digastric muscle is what forms the boundaries of the supraomohyoid neck. This includes levels 1, 2, and 3. 100% appropriate to restrict the dissection to those levels in the N0 neck. But once you have a positive lymph node, even if it's only palpable at the time of surgery, it would be wise to include level 4 in that dissection because of the data that's come out of Memorial Sloan Kettering, Professor Shaw and Professor Spiro. Now, what about distant metastasis? Distant metastasis, overall incidence for all stages is about 15 to 20%. The risk factor is the higher the stage of the disease, the higher the chance of distant metastasis, and then any recurrence at the primary or the neck increases the chance of distant metastasis. For oral cavity and head and neck cancer, the most common sites of spread are the lung, followed by the liver, followed by the bone. That's why the metastatic workup for distant metastasis will include a PA and lateral chest X-ray. If something shows up on the chest X-ray, then one can order a more expensive CT scan. If the liver function tests look abnormal, then one can order a CT of the abdomen to rule out involvement of the chest or involvement of the abdomen, because distant metastasis may affect the overall prognosis and the overall treatment plan for the patient. And then, of course, the PET scan is becoming more and more routine in the overall metastatic workup, as well as the surveillance of patients with head and neck cancer. If you look at the stage distribution and survival by stage for oral cancer, again, stage 1 has the best overall 5-year survival. Stage 2, it drops to about 65 to 85%. Stage 3, 45 to 65. And if it's a stage 4 cancer, overall survival is about 15 to 30, 35% at best. So the higher the stage, obviously, unfortunately, the less the survivability. But again, a majority of these can be picked up in stage 1 and stage 2. Why? Because the accessibility to the oral cavity, the dental hygienist, the dental assistants, the dentists, the oral surgeons that can pick up on this. By far, the dental community and the dental profession is much more adept at doing an oral exam than the physicians are. We know. I mean, I can tell you, I went to medical school. The amount of understanding of the oral cavity is very, very limited by the medical profession. So it's really dependent upon and the importance of this type of program that you guys have. The program that King Rama has established for you is really important in the management, not just of dental implants, but also understanding the importance of early identification of oral cancer. What about the neck management for oral cancer? How do we manage the neck for oral cancer? And really, it's pretty simple. If the clinical exam shows a neck node, then they need a neck dissection. If the clinical exam does not show any palpable adenopathy, then it depends on the location of the tumor and things like that. And we're going to talk about those things in just a minute. But the other important concept to understand is if the patient is going to receive radiation and they have an N0 neck, that neck dissection is equivalent to radiation in the eradication of microscopic disease in the neck. Oh, the only difference is both the neck dissection and radiation have potential complications. I, as a surgeon, think that the complication rate of radiation is higher than it is for neck dissection, simply because we've seen some of the complications of this, or I shouldn't say complication, I should say side effects of radiation, including xerostomia, including cervical caries, including osteoradionecrosis of the mandible, and things like this. So here we'll talk about types of neck dissections, treatment based on the site of the cancer of the neck, and then treatment based on the nodal status. So this is from Netter's book. This was an article that was written by Hayes Martin, sort of the father of modern American head and neck surgery. And basically, there are three major types of neck dissections. There's the radical neck dissection, the modified radical, and then the selective neck dissection. When we talked about omohyoid and doing levels 1, 2, and 3, this is actually a selective neck dissection. In a selective neck dissection, you are selecting which levels of lymph nodes you want to remove. As opposed to the radical or the modified radical, you're removing all levels of lymph nodes from levels 1 to level 5. Usually level 6 in the anterior compartment is only removed during treatment of carcinomas of the thyroid or parathyroid gland. So look at radical neck dissection. This shows a radical neck dissection schematically. It includes all lymph nodes in levels 1, 2, 3, 4, and 5. It also includes removal of the spinal accessory nerve. It includes removal of the internal jugular vein, and it includes removal of the sternocleidomastoid muscle. Now, does this need to happen nowadays very commonly? Probably not. Probably not. I did maybe I do 2 a year of the actual radical neck. Most of the neck dissections we do now are either selective neck dissection or modified radical neck dissection. What's the difference? Again, the radical neck removes all of the lymph nodes, just like the modified radical does, but the modified radical will preserve one of these three structures. It will preserve either the spinal accessory nerve and or the IJ and or the sternocleidomastoid. So what determines whether you preserve or remove these structures? What determines it is the involvement of the lymph node or the cancer in that area. If the spinal accessory or the IJ is deeply involved and infiltrated by cancer, then no one has a choice other than to remove that structure as well. Fortunately, the common carotid artery and the internal carotid artery are less commonly involved with tumors. The IJ is more commonly involved. A modified radical neck dissection really has three subtypes: subtype 1, subtype 2, subtype 3. Again, as I mentioned earlier, the modified radical includes removal of the same level of lymph nodes as the radical. It preserves one or more non-lymph node bearing structures. Type 1 really is the most common type. It preserves only the spinal accessory nerve, and it sacrifices the IJ and the SCM. Type 2 preserves the spinal accessory and the IJ, and it sacrifices the sternocleidomastoid. Type 3, which may also be called a functional neck dissection, actually will preserve all three structures but remove all the lymph nodes. Now, the other type of neck dissection, which has now become the most commonly done neck dissection in the United States and probably worldwide, is the supraomohyoid neck dissection. There are other forms of selective neck dissections, including the posterior lateral, which is done for carcinomas of the scalp and posterior neck, the lateral neck dissection, and then, of course, the anterior compartment dissection, which is mainly done for cancers of the thyroid or parathyroid region. Again, this is selective because it's selecting out some levels and leaving other levels of lymph nodes. So the supraomohyoid is the one that you see right here, which includes all of level 1, all of level 2, and all of level 3. This is the most common selective neck dissection, which is done for cancers of the oral cavity, which on clinical exam are N0. In other words, they have no palpable adenopathy. Why? Because I told you before, once you have a palpable node, the chance of picking up nodes in level 4 goes up. So this strictly a supraomo is not recommended in the N positive neck, only in the N0 neck. Now, so if you look at neck treatment for lip cancer, here's a typical lip cancer. Certain parts of the United States more common than others. We know that lip cancer is more commonly associated with sun exposure, solar exposure. But again, it drains, cancers of the lip drain to levels 1 and level 2 of the neck. Those are lower lip cancers. The upper cancers, upper lip cancers, have a tendency to spread to those same levels, but they may also spread to the periparotid nodes. So when you have an upper lip cancer or a cancer of the commissure of your lip, not lower lip, but commissure or upper lip, you need to also carefully examine clinically and through CT exam the presence of any adenopathy that may exist in the parotid area, because they tend to spread there as well. So for stage 1 and stage 2 lip cancers, no real treatment of the neck needs to be done. For stage 3 or stage 4, if they have a positive neck, they need to have a neck dissection. But if it's a stage 3 or stage 4 lip cancer and they have no palpable adenopathy, it's recommended that you do an elective neck dissection on the patient, or at minimum electively radiate that patient, radiate their neck. If you look at cancers of the buccal mucosa, like you see here, this goes to level 2 and level 1. The overall risk of metastasis to the neck is about 10%. So if you have a T1 or T2 lesion, no elective neck dissection is required. You only do a surveillance of the neck. Surveillance of the neck. If it's a T3 or T4, stage 3, stage 4, then an elective neck or at minimum radiation is recommended. What about the alveolar mucosa? Alveolar mucosa can be very tricky. It goes to levels 1 and levels 2. And the mandible tends to metastasize a little earlier than the maxillary lesions, but both have a potential. And these are very tricky lesions. So anything that's a T2 lesion or greater, I will do an elective neck dissection on the patient. What about the retromolar triangle? Retromolar triangle, very tricky, and very early potential for metastasis. So this goes to levels 1 and levels 2. So if I have a retromolar trigon cancer and a CT scan and clinical exam shows no palpable adenopathy, I will still do a supraomohyoid neck dissection on this patient for anything larger than a T1 lesion. The hard palate, same thing. If it's here, slightly less risky, but if it's a T3 or larger lesion, I will do a neck dissection on that patient. Also, something to remember, if I have a lesion like this, that's a fairly large lesion, and it's a T2 lesion with some small erosion, and I'm going to do a maxillectomy, I may decide to do a neck dissection depending upon if I'm going to reconstruct this with an obturator, which I would not do the neck dissection, or if I'm going to do a free flap reconstruction. If I'm going to go into the neck and do a free flap reconstruction and anastomosis, if I'm going to go into the neck, then I'm going to go ahead and do the neck dissection because I could save the patient potentially the need for elective radiation. If I do the neck, no, and the lymph nodes show no involvement, I may decide no radiation for these patients. The tumor board will be done, and the tumor board will say N0 neck clinic pathologically, so no neck dissection is necessary. What about the oral tongue? Probably the oral tongue and the floor of mouth are the two most trickiest areas because not only is the size of the lesion important, but the thickness of the lesion becomes very important. The metastasis, even for early lesions, can be 30 to 40%. What's the threshold? And we'll talk about that in a minute. Any lesion you see in the oral cavity, very simple. If they have a lymph node that's palpable, very simple. They need a neck dissection. If there's an oral cavity lesion and they don't have a lymph node in it, if the potential risk for spread, occult metastasis, is 20% or more, then you should do a neck dissection on the patient. Here with tongue lesions, overall, the risk is very high. So unless it's a very thin meaning less than 2 millimeters in thickness, oral tongue cancer, if it's less than 2 millimeters in thickness and it's a T1 lesion, then I will do no elective neck dissection. I will just observe the patient. But if it's anything thicker than 2 millimeters or anything greater than a T1, the patient's going to get a neck dissection. Same thing for the floor of mouth. Same thing for the floor of the mouth. Thin T1, no elective neck dissection. Thick T1 needs to have an elective neck dissection. If you look at this slide from Dr. Shaw's book, you notice that the risk of occult metastasis, if it's less than 2 millimeters in thickness, this is for tongue and floor of mouth, is about 13%. If it goes to 2 to 9 millimeters in thickness, the risk is 46%. When it goes to more than 9 millimeters in thickness, it's 65%. So these are unacceptable percentages. So anything greater than a small, thin T1 lesion, anything more than that needs a neck dissection, or at minimum, radiation of the neck if it's an N0 neck. So if you look at the overview of the neck treatment for the N0 neck, and this is an article by Weiss in the Otolaryngology Journal from 1994, if the occult metastasis potential is greater than 20%, one should do an elective neck dissection, at least levels 1, 2, and 3, versus radiation of the neck. Man, the decision is up to the clinician. If it's a patient that's not very fit for surgery, maybe radiation would be an option. If the occult metastasis potential is less than 20%, it would be appropriate to just observe and do surveillance on the patient. All T3 lesions need a neck dissection or treatment of the neck. T2s in high-risk areas need treatment of the neck. This includes alveolar mucosa, retromolar trigon, tongue, and floor of mouth. Thick T1 lesions greater than 2 millimeters in thickness, 2 millimeters or greater in thickness of the tongue and floor of mouth need neck treatment. Thin T1 lesions of the tongue and floor of the mouth need at least careful neck observation, meaning at least twice a year they need to be observed. For the N positive neck, it's very simple. They need a neck dissection. Here, what comes in is the need for post-op radiation. The common criteria include more than one positive node, the presence of extracapsular spread or disease beyond the node, advanced disease, or close or positive margins. Now, I'd like to show a couple of case examples, and then we'll open it up for any questions that the audience may have. But, this is a squamous cell of the tongue. You can see the lesion here very nicely. This is a lesion that if you take 1.5 centimeter margins, which is the degree of margins that I have become accustomed to taking, not 1 centimeter. See, the problem is you do a centimeter margin, the pathologist looks at it, and histologically it looks normal, the margin. But who knows what's going on at the molecular level and the potential for recurrence at the molecular level. So I think it's important, at least in my mind, maybe 40 or 50 years ago when we did not have the reconstructive techniques that we have now, we tried to be more conservative. Maybe I can get away with doing half a centimeter or 1 centimeter margin. Now, I think 1.5 centimeter margin. So if you take this kind of lesion and you do a 1.5 centimeter margin, basically it becomes at least a hemiglossectomy. Most patients don't do well with a hemiglossectomy unless you do some type of reconstruction. Back in the old days, maybe a pec flap, deltopectoral, pec flap, something like that. But nowadays, the standard of care is some type of microvascular free tissue transfer. And the most common one that we like to use for the tongue is either the radial forearm flap or the anterior lateral thigh flap, those two flaps. There's nothing that's changed in the preoperative workup for this kind of patient because it's a simple soft tissue flap. With the radial forearm, you just have to do an Allen's test to test for collateral circulation in the ulnar branch so that the radial artery can be harvested and not cause any ischemia of the hand. So the preoperative workup is not difficult here. But here you can see another case. You can do here, there's a marginal, this was a squamous cell, which is abutting up against the lingual margin of the mandible and the ventral tongue. So here, a partial glossectomy of the ventral tongue and a marginal mandibulectomy. When we can do a marginal resection of the mandible, we do a marginal resection. It protects the integrity of the mandible. They could potentially still get implants depending on how much mandible is left behind. But certainly you don't have to create a segmental resection of the mandible. So here's this example. This can be reconstructed with a radial forearm. You can come back later and put implants in the residual mandible, because you can see we've only taken about 8 millimeters of the mandible here because the squamous cell was just abutting the lingual cortex, but was not grossly invading the mandible. But what about this case here? This is a gentleman that has a larger squamous cell carcinoma, and I don't have the panoramic radiograph to show you, but if you look here, you can see how it's eroded on the top right slide, eroded into the mandible. So in this case, because of the size of this lesion, the size of the soft tissue involvement, and the erosion into the mandible, we necessitated a segmental resection. So back in the olden days, we would do a segmental resection and we would harvest the fibula and try to make it fit. Nowadays, as you guys know from your training in dental implants, actually we learned this from the dental implant people, to do this virtual surgical planning. So now we take the virtual surgical planning and we plan the case. It allows us to, we take a CT angiogram of the lower extremities. We make sure the perineal vessels, in this case, we're going to do a tracheotomy on the patient. We're going to do a composite resection of the mandible, which, as you can see, includes the coronoidectomy, almost like an IVRO cut, includes the coronoidectomy, a segmental resection of the mandible. Then we're going to reconstruct the mandible with the fibula. In this case, it can be a straight shot fibula, one-piece fibula, very simple reconstruction. So here you can see the left fibula on the top left, the mandible resection, and the mandible reconstruction. We will use a combination of 2.0 and 2.3 millimeter bicortical screws to reconstruct this. Also, we will have a custom cutting guide. You can take this completely off the cone beam CT scan. We'll have a custom-made cutting guide. I like a one-piece cutting guide. It's much more accurate. Notice how the cutting guide overlaps the inferior border of the mandible and how it overlaps the posterior border and the posterior lingual aspect of the mandible. So you get a very snug fit. Included in this cutting guide is an area that you're going to make your predictive holes for your plate. So once you bring the fibula with the plate, you can plate the fibula at the leg and bring it up and just inset it directly into the mandible, into the occlusion, and the occlusion is perfect and the fit is perfect in most cases. So here you can see the cutting guide with the predictive holes that will go into the final plate. This gentleman had two previous implants that were placed earlier. Here you can see the evidence of the cutting guide and the predictive holes in the proximal segment and in the distal segment. So what you can notice here is there's a specific length, and then the cutting guide here on the bottom left will fit directly into the fibula, and you will take that segment of the fibula with you. It also will allow you to place your predictive holes and your fixation holes. The plate can then be brought either to the leg, as you can see here. This shows an anterior, lateral, and posterior view of the cutting guide on the fibula. So we have cutting guide for the mandible, we have a cutting guide for the fibula, and then you can see how the fibula will fit directly into the mandible. This is really the most current thing that's now come up in head and neck reconstructive surgery is the virtual surgical planning for these type of cases. So what is provided is the actual titanium alloy mandibular plate, the titanium alloy fibula cutting guide, and the titanium alloy mandibular cutting guide. So this will make the cuts, and then the fibula will slip directly into there with very, very minimal minor contouring. Additionally, you can use a heat map to show you the thickness of the mandible, so you don't even have to use a depth gauge. You don't even have to use the depth gauge. So here shows clinically the same gentleman. We have done a segmental resection. We did a supraomohyoid type of neck dissection on him. You can see the fibula has been marked with the paddle. And then this, of course, this is just a schematic of it. And then on the top right, it shows the specimen removed, the fibula, along with the skin paddle. Here you can see intraorally the skin paddle in place on this gentleman, and you can see on the panoramic radiograph what that looks like. And what's changed here is we now know that if we want to implant the fibula, it's more important to place the fibula a little bit higher, not at the inferior border, but a little bit higher. And that allows for a better crown to root ratio with any implants that we want to place into the neomandible. I'll show you another, just a quick one for the maxilla. Same type of thing. A diagnosis of squamous cell carcinoma of the maxilla. Notice the margins are 1.5 centimeters. This is very easily approached through a transoral approach. No need for a Weber-Ferguson. I look at Ohngren's line and I determine whether there's involvement at the pterygoid level or greater. If there's pterygoid level involvement, I'll do a Weber-Ferguson. If there's not, I'll just do it transorally. Here you can see the generic fibula harvest. You can see the amount of maxilla that we're going to resect and then the proposed reconstruction. You can see the resection of the mandible, including the palate here. And then you can see the cutting guides. I don't like this has two independent cutting guides. I prefer the cutting guide that's connected because it's more rigid and it's more accurate. But here you can see the overlapping of this here and here. So now when we do this maxillectomy, that means that we have to open this up at the Lefort 1 level in order to achieve this level of exposure to put the cutting guides. But I think it's worth it because the cutting guides are very specific in how you cut the maxilla. And when you cut it this way, it then makes the fibula or the iliac crest, whatever flap you want to use, fit perfectly. So you can see here that this is going to be unlike the last one, which was a very simple single cut, straight shot fibula. This fibula we will cut into two segments, one at 17 and one at 27 millimeters approximately, that you can see here. You can see the schematic on the top right. You can see the predictive holes so that when we bring this one piece plate and put it in, the holes are already drilled at the time that we put in the cutting guide. This shows the single plate and the plate of fixation here, the fixation on the piriform, and the fixation in the sublabial region here. This just shows it, I think, quite nicely here. This shows the special cutting guide because this is not a one-piece fibula, this is a two-piece fibula. So it's going to show the way that the fibula is cut so that it can create the closing osteotomies. As I mentioned before, you can see here, this is a heat map, which very easily, just from a cone beam CT scan, you can get the heat map, which will illustrate very nicely the thickness of the bone. So you can shape the plate to where the best bone is, and again, you can tell you how thick it is. So this shows that particular lady with the harvesting of the fibula. Here's the two-piece segment, and then we're going to bring it together and plate it, and then put everything onto the maxilla. And then very simple. Here you can see, I just show you an example of what it looks like ready. It looks almost perfect. It fits the maxilla perfectly. Very difficult. It was somewhat easy to do the mandible, but it's much more difficult to three-dimensionally construct the maxilla. So finally, I want to show you the very last one, and this just shows the fibula here. So this was a post-ablative defect, squamous cell carcinoma resected. The lady was wearing an upper prosthesis with an implant. She did not like it. We took her and did a reconstruction on her utilizing the fibula. Some people criticize the fibula, but I think the fibula is even better than the DCIA for implantation. Here we did this as a staged reconstruction. Occasionally we do immediate implants, particularly with benign disease, but in malignant disease, I prefer to do staged. I don't like to put implants in people that are going to get radiation right away. Again, some people do it differently. I took the patient back. I debulked the flap. and then I place implants. Here you can see the flap, I debulk it. Here's the new ridge of the maxilla, and then we place implants. Here you can see, maybe I got a little carried away. I don't think I should have put this last one. This would have been sufficient. The prosthodontist decided he wanted to place a snap-on prosthesis. Here you can see the hole is obturated nicely, and then the lady here is very happy post-operatively, and here you can see her prosthesis, and she's doing very, very well. And of course, I mentioned TORS. We're doing more and more of the transoral robotic surgery using the Da Vinci robot, and it's a very successful technique that avoids more invasive approaches, which may include a lip split or a mandibulotomy to approach lesions of the tonsil, base of tongue area. I also like to use TORS, and maybe Mr. Chairman or Witchett, I can come back in the future and give another discussion about robotic surgery for sleep apnea, where we're doing a UPPP and base of tongue resection in addition to maxillomandibular advancement. So I thank you guys for the time and for this presentation, and I look forward to your questions. And again, I thank His Majesty the King for creating this program for your country. Thank you very much.
Thank you very much, Professor Ghali, for your nice presentation and very update in the treatment of the head and neck cancer. So there are some questions. I will look for the first question is, what is the difference between the skin squamous cell carcinoma and oral squamous cell carcinoma? In case of the carcinoma of the lips, is its behavior different from other area of the oral cavity?
Yes. So in general, skin cancer, which is as a result of exposure, excessive exposure to ultraviolet radiation, has overall better prognosis than oral cavity cancer. That's a good general statement. And then, in general, lip cancers are more commonly associated with sun exposure. So lip cancers are more like skin cancers than they are lip cancers. This is only if they occur outside or external to the wet line. When they go into the wet line, then for all intents and purposes, they become a traditional oral cancer. So the difference is if you have a T1 lesion, regardless of how thick it is, in the lip externally, particularly if it involves a vermilocutaneous, you're never going to need a neck dissection, even for a T2 lesion. But if you had that same lesion located inside the vestibule of the mouth or in the floor of mouth or tongue, then it's a totally different story, requires neck dissection or at least irradiation of the neck. I can't hear you now. I'm sorry.
Okay, thank you very much for your answer. And let's go for the next questions, which is mostly interested in the area of the cancer of the lips. So as you mentioned in your lecture that the squamous cell carcinoma of the upper lips or lips commissure mostly use metastasis to the parotid lesion, right? Is that because of the lymphatic drainage?
Yes, good question. And yes, it's because of the lymphatic drainage. So basically, because of the commissure and the upper lip, the first echelon of lymph node is in the periparotid nodes. So if you have someone that has a lesion of the upper lip or the commissure area, that is a large, T3, T4 lesion, then in that case, it's recommended to do a superficial parotidectomy as a part of the resection.
So you mean that we do the superficial paroidectomy whenever there is a metastasis or just
Yeah.
only?
Well, I think at minimum, what you should do is you should get a CT scan or an MRI of the parotid area. And if there's any question of any lymph node in that area, then you should do a superficial parotidectomy. Again, if the patient has a large T3, T4, the tumor board recommends radiation postoperatively, then it's probably also wise to radiate the parotid area because this is the first echelon of lymph node involvement from upper lip and commissure lesions.
Okay, thank you.
Yes.
So the next question is regarding to the fibula. Does placing the fibula close to the oral site to improve the crown root ratio of the implant will affect the external appearance of the patient?
Yeah. So this is also a good question, and most of the time, with the fibula, we will wrap some of the soft tissues around the fibula, some of the muscle around the fibula. So usually that muscle will fill the area and not cause much of an aesthetic defect in there. I would say 90% of the time, it's not even perceptible by raising it about 0.5 centimeter to bring it closer to where it's much easier to do implant. Obviously, another option is to do a double barrel fibula, where you have one and then you put one on the top of it. But again, that is a riskier procedure. And in our experience, moving the fibula up a little bit, and you can see how the plate is made, and it goes like this, and then it goes up a little bit like that. That's on purpose to position the fibula a bit higher. We've not seen much of an aesthetic problem, and I think that's mainly because we preserve a bit of the muscle and attach the muscle from the leg. The muscle stays attached and fills in the inferior border area.
I see. So you mean you use the volume of the soft tissue to reconstruct the lower border like that,
Yes.
right?
Yes, sir.
Yeah. Thank you very much for this answer. And let me check. For those who still have a question, you can type in the chat and then I will ask the presenter. Next question is, whenever we have a difference between the clinical staging and the pathological staging, which mostly the pathological staging is beyond to the clinical staging, right? So in that case, what is your further treatment of choice?
Yeah. So yes, I think the pathologic staging is much more important than the clinical staging because in the pathologic staging, they're going to take into consideration the margins, positivity of the margins. They're going to take into consideration certainly in the clinical, you can measure the lesion and you can feel the lymph nodes, but you don't know whether the margins are going to be clear when you resect them. You don't know whether there is perineural invasion or perivascular invasion. You don't know if the lymph nodes have cancer in them or not. Just because you palpate them doesn't mean that they have cancer in them. You can see it histologically or not. You don't know whether there is extracapsular spread or not, or disease that goes extranodal disease. But you can determine this pathologically. All of these variables become important when you're considering any need of neoadjuvant or post-operative chemoradiation. So these are all really important variables in determining whether the patient is going to need any additional treatment post-surgery. And again, sometimes they're very difficult questions. That's why I think I want to emphasize it's very important when you're treating, just like when you treat cleft lip and palate. You want to have a team. It's a team effort. You need different specialties. You need speech pathology. You need otolaryngology. You need these different different specialties, pediatric dentistry, orthodontics, etc. Like when you do implants, you need to have a multidisciplinary team, not just one dentist or one prosthodontist or whatever. You need to have a team, and also with head and neck cancer, oral cancer, you need to have a team. So the team sits around and makes a decision about this was the clinical staging, this is the pathologic staging, and what is in the best interest of the patient. And then also variables is the quality of life. Is the patient fit enough to handle surgery? Are they fit enough to handle radiation? I mean, radiation can be difficult for some patients. So these are all variables that I think are important. But I'm so happy to hear that in Thailand, you guys are doing more and more oral cancer. And I know Dr. T is there. Hopefully he's doing some more and more oral cancer as well.
Thank you very much. And the next question is as you mentioned in your lecture about the digital technology that can help us in terms of the assist for the surgery. How often currently do you use this technology for your cancer surgery?
Yeah, that's a good question. So I use this technology whenever I can use it because at first I was a little bit skeptical about some of it, but it saves a lot of time in surgery. It makes the surgery more accurate. I think it's better for the patient. It's more accurate. It allows me actually to show the patients preoperatively, this is what we're going to do. This is the plan. And I think really it shows the patient and the family that you're really spending a lot of extra time to try to do the best thing for the patient. So any oncologic case that I have that's going to include a bony resection, unless it's just a marginal resection. If it's a simple marginal, and like I showed you the sample, it's no problem. But anything that requires a segmental resection or anything in the maxilla that requires a resection, I will do a digitally planning of the patient. Also for orthodontic surgery, if it's a double jaw, I'll do, orthodontic planning. For very complex implant patients, I'll do digital planning. For certain trauma, I will do it. If it's a custom joint, I'll do it. If it's a orbital, I'll do it. Simple mandible fracture, simple Lafort, no. Single jaw surgery, usually not. Double jaw surgery, yes, I'll do the surgical planning. So I use it a lot. Probably to answer your question, for head and neck cases, probably 90% of our cases, unless it's just a radial forearm or just ALT, other than that. Now, sometimes we will do just a radial forearm or just a ALT, and we'll do a plate. If it's a patient that's kind of sick and they cannot handle an 8 to 10 hour operation, we can do a radial forearm in 2 hours and do at the same time we do the resection, put a plate. Well, we'll get a custom plate so it fits a lot easier, and we don't have to worry about putting them in MMF. We don't have to worry about the occlusion. All of that can be incorporated into this digital treatment plan.
I totally agree with you that nowadays we implement the digital technology into our surgery more and more. And
Yes,
this is
yes.
a very good sample for cancer surgery that you show us today. And
And, I think it's the most, it's the best advance that we've had in head and neck surgery. There's improvement now in certain things, certain cancers where with immunotherapy, for example. But for the most part, the microvascular hasn't changed. The ablation hasn't changed. What's changed is the workup of the patient and trying to make the surgery more smooth, less time in the OR, and more accuracy. That's the main thing.
I agree that. And for that digital technology, do you have your own facility in your center, or you use the outsource?
No, we use the outsource. I mean, we have a 3D printer where we can do 3D printing, but not for titanium, not for the high grade titanium. So the turnaround for a custom orbital is about 3 to 5 days. The turnaround for something like or a double jaw surgery with the splints or things like this, as well as the custom plates and things like that, is usually about 8 to 10 days. And the turnaround for this type of surgery that you saw with the custom cutting guides and things like that for fibula is usually around 10 to 12 day turnaround. So with the cancer patients, as soon as we get them in and we do the workup and we get the cone beam scan, we send it off and then we schedule a planning session with the engineers. We do it virtually and we have it almost always, because typically these patients require a fairly exhaustive workup because they're not the healthiest patients. They need to get cardiac clearance. They need to have a CT angio of the extremities to make sure the perineal vessels are fit. They require a significant, so from the time that we first see a cancer patient till the time we operate on them, at the earliest is going to be about 3 weeks, somewhere between 3 and 6 weeks. So this gives plenty of time to get the workup. With the orthognathic, within 2 weeks, plenty of time. In the trauma, within 3 to 5 days, so usually plenty of time as well. By the time the swelling goes down for the orbit, you operate on them and you do the orbital reconstruction. But I think it's better for the patients.
Yes. Thank you very much. And hopefully this is one of the last question. So as we all know that the genome project has been implemented and almost finished for a long time. And one of the objectives of the genome project is to identify the gene that's related to the cancer oncology, right? So do you have any experience of using the gene therapy or any gene investigation combining with the surgery in your center or in United States?
Yes, we have some capabilities here, just as well as at MD Anderson and places like that, where we can do the genomic sequencing. And we're doing the genomic sequencing now on most of these cancers that we're removing. Again, it's a very difficult process. It's not easy. I don't understand it fully like the researchers do, but I think that's the goal. And if you look at a place, for example, the place that Danny Thomas started in Memphis, Tennessee, St. Jude Hospital, which is very world famous for pediatric oncology, they are sequencing every tumor, every single tumor that they treat, they sequence it, and they're finding that this allows very much targeted therapy for these patients. Targeted therapy is become more and more important, particularly when you talk about immunotherapy and for things like melanomas and the oral squamous cell carcinomas. So yes, we're suggesting that we're doing genomic sequencing on all of these patients now, and I think we're going to get more and more results over the next few years. Yeah.
Thank you very much.
Thank
And let me check any other questions. So I think that is all questions from the audience. So I would like to thank very much Professor Ghali for your time and your contribution to our online webinar of the King Rama IX Study Club today. And we hope very much to have you on site in Thailand in the near future. Thank you very much.
It will be my pleasure. Thank you, Mr. Chairman. And again, thank you for all the audience and the opportunity and the invitation from Wichit. Thank you. Congratulations to you. And thank you. And good morning, good night. And I hope to see you guys soon in Thailand. Thank you.
Okay, see you. Bye-bye.
Bye-bye. Thank you.
For those audience who attend this online webinar, please don't forget to evaluate by scanning the QR code right now on your screen, and stay tuned with us for the next year of the online webinar. There will be more and more interesting webinar for you. Next year, we plan to have another 4 online webinar, and the information of this online webinar will be promoted in the social media, as you know. For today, I think we have finished everything here, and do we need anything left? And see you again next year. Thank you. Bye bye. สวัสดีครับ